Welcome back, everyone. I am absolutely thrilled to have you here for part 5 of our Evaluation and Management Explainers series. Today, we are setting the stage to decode the very bedrock of medical decision-making, or MDM. We're going to focus intensely on MDM Element 1, which is the number and complexity of problems addressed. Specifically, we're mastering the foundational tiers, straightforward and low complexity levels. For all my medical coders, billers, auditors, and CDI specialists out there, you know the drill. If you don't get this first element right, the entire E&M level can literally collapse. So let's dive right in and build our scaffolding from the ground up.
All right, here is our roadmap for today's explainer. We're starting with Section 1, defining what a problem address actually is. Then we move to Section 2 to decode straightforward complexity, followed by Section 3, where we'll define low complexity problems. In Section 4, we'll put straightforward and low complexity head-to-head, and we will wrap up in Section 5 with some key takeaways and a teaser for Part 6.
Okay, let's jump straight into Section 1, defining problems addressed, which is really the core foundation of Chart A.
So, the crucial starting point is this official guideline definition. For a problem to actually count on your MDM grid, it absolutely must be evaluated or treated at the visit, specifically by the provider reporting the service. Listen, this is not just about listing a bunch of diagnoses on a page, it's about active hands-on management. And what's really interesting here is that this explicitly includes consideration for further testing or treatment, meaning even if the patient ultimately declines a treatment after a risk-benefit discussion, the cognitive work was still done by the provider, right? So it counts.
Now here is the stark dividing line between compliant coding and, frankly, a total audit failure. You've got what counts: active evaluation, active treatment, and documented consideration of further testing. But wait, look at the flip side. What doesn't count? Simply referring a patient to another provider without actually evaluating them yourself first, or just transferring a massive problem list into your notes when another provider is the one actively managing that specific issue. We really have to train our providers to show their work.
I want to pause right here on this quote, straight from the AMA guidelines, because it is a massive documentation trap. It says, notation in the patient's medical record that another professional is managing the problem without additional assessment or coordination of care documented does not qualify as being addressed. Guys, if your provider just writes, cardiology is managing the AFib, and literally does nothing else with it, no assessment, zero care coordination, auditors are going to strike that problem right off Chart A. It's a passive notation, not an active problem addressed.
Quick side note before we leave these foundational rules, this is a critical reminder for our facility coders. When you're dealing with hospital inpatient and observation care services, the problem addressed is based on the status of the problem on the specific date of the encounter, the face-to-face visit. It might be significantly different than what it was when they were first admitted. You're scoring the problem being managed that day, which, might not even be the original cause of the admission in the first place.
Let's step it up to Section 2, decoding straightforward complexity. We're stepping onto the very first tier now. The absolute lowest level of problem we track is a minimal problem. Think of this as a problem that might not even require the physical presence of the provider in the room, but the service is still provided under their direct supervision. For my outpatient coders out there, you'll immediately recognize codes like 99211, which are often our nurse visits, or 99281 in the emergency department. It's clinical, it's supervised, but as the name implies, the complexity is minimal.
Still hanging out within that straightforward tier, we also have the self-limited or minor problem. The key phrases to latch onto here are prescribed course and temporary in nature. This is an issue that is highly unlikely to permanently affect the patient's overall health status. Think of a minor viral cold or maybe a simple localized rash. It's something that's going to resolve naturally on its own or with very basic intervention. Just one minimal problem or one self-limited problem lands you right in the straightforward category for Element 1.
Moving right along to Section 3, defining low complexity problems. This is where we advance the clinical nuance.
All right, this is where clinical definitions get much more rigorous, and honestly where CDI specialists can really make a huge impact. To score a low complexity on Chart A, you've got to hit one of these specific triggers. You need either 2 or more self-limited or minor problems, 1 stable chronic illness, 1 acute uncomplicated illness or injury, 1 stable acute illness, or an acute uncomplicated issue that was significant enough to actually require inpatient or observation care. Let's break down exactly what these terms mean clinically, because guessing here is just going to lead straight to coding errors.
Now, I need you to pay really close attention to the strict definition of a stable chronic illness. A chronic illness has an expected duration of at least 1 year, or until the death of the patient. But here is the kicker. The word stable is what trips everyone up. Stable literally means the patient is at their specific treatment goal. If a patient has persistently poorly controlled blood pressure and better control is the stated goal, they are not stable, even if their pressures haven't changed since the last visit and they have 0 symptoms. The condition has to actually be at the goal to be considered stable.
Let's anchor those abstract guidelines with some concrete clinical examples straight from the source text. We're talking about things like well-controlled hypertension, non-insulin-dependent diabetes that is well managed, cataracts, or benign prostatic hyperplasia, commonly known as BPH. If your provider documents that these specific conditions are at their treatment goals, boom, you confidently have one stable chronic illness, which immediately gives you low complexity for this element.
Another trigger for low complexity is an acute, uncomplicated illness or injury. Basically, this is a short-term problem with a very low risk of morbidity. Crucially, there is little to no risk of mortality with treatment, and a full recovery without any functional deterioration is completely expected. Simple, everyday clinical examples here include things like uncomplicated cystitis, allergic rhinitis, or, just a simple ankle sprain.
You can also trigger low complexity with a stable acute illness. Now, this one requires a bit of medical history detective work. This is a problem that is new or recent, but treatment was previously initiated. The patient is actively improving on that specific treatment, but the condition just isn't 100% resolved yet. Making sure you differentiate this from a brand new acute problem is absolutely key to keeping your coding highly accurate.
Let's move to Section 4, straightforward versus low complexity. It's time for our deep dive comparison.
Doing a side-by-side comparison like this is brilliant for illustrating how to confidently distinguish between the two levels. Take a look at the number of problems. Straightforward is triggered by just one minimal or one minor problem. But to bump up to low complexity, you need 2 or more minor problems, or just one stable chronic, or one acute uncomplicated illness. Also, notice the shift in duration and nature. Straightforward is strictly temporary. Low complexity introduces chronicity, meaning conditions lasting a year or more, or acute issues requiring some medical intervention for a full recovery. Keep this mental matrix handy, and you for sure won't overcode or undercode these foundational visits.
And that brings us to Section 5, key takeaways and teaser for Part 6. Let's wrap up this part of the explainer.
Seriously, if you take absolutely nothing else away from today, please remember these vital compliance lessons. Number 1, active management is totally required. Passive notation of another provider's work does not count. Number 2, referring a patient without evaluating them first means the problem was never actually addressed for your MDM. Number 3, remember that stable is a clinical achievement of a specific treatment goal, not just the absence of an immediate emergency. And finally, use the criteria we just covered to keep your straightforward and low complexity definitions strictly separated when you're auditing charts.
Before we go, I want to leave you with this somewhat provocative question to take back to your practices and facilities today. Ask yourself, are your providers actively documenting their specific treatment goals to actually justify a stable chronic illness? Because if they aren't, your CDI team has a massive, immediate opportunity for education right there. Coming up next in our series is Part 6, where we are going to conquer the absolute top tiers of the MDM grid, mastering moderate and high complexity problems. You definitely won't want to miss seeing how drastically the definitions shift when the clinical risks get higher. Until then, keep auditing, keep educating, and decode healthcare with Harshal.